So, Alan, you introduced perfectly here. We've talked about ORBITA 1, we've talked about ORBITA 2. I'm going to introduce ORBITA 3, which is really the application of clinical trials like ORBITA and others and with regard to PCI's impact on patient-reported symptoms and clinical outcomes in real-world clinical practice, so in areas that are unstudied, with a takeaway that there's no singular study that's exclusive to informing a shared decision-making process. This is a case that I've only been recently involved with in the past 2 months, and it's a 57-year-old software engineer living south of Atlanta who, at least until recently, had unrecognized familial hyperlipidemia with an LDL approaching 170 with no therapy. And he presented one of our affiliate hospitals with class 3 angina, but also profound dyspnea. And by echocardiography, his ejection fraction was 15%. He underwent coronary angiography at that institution, and it demonstrated quite complex disease, as we might expect. His LAD has a proximal, if not mid, total occlusion with left-to-left collateral filling. He's got moderate mid-left circumflex disease, and then his right coronary artery is also occluded proximally, and the distal right fills by both right-to-right and left-to-right collaterals, and then there's this Vuessen's ring, that this atrial collateral that crosses over and fills the entire anterior and apical segments of his heart. So the patient was transferred to our institution where he underwent cardiac MRI and amazingly had very little scar and no evidence of infarction whatsoever. So he had complete viability in all territories by MRI. At this point, Pam, what would be your next thoughts for this person? Would it be advancement of medical therapy alone? Would you have surgeons and or interventionalists?
I would call Marco.
Yeah. You would call Marco. All right. And Marco, what would your thoughts be for this gentleman?
So, right at this moment, high surgical risk, right? So the question that we would have in our heart team discussion is, obviously we need to revascularize the heart. Should we try optimal medical therapy to see if there's any recovery in function and then go for revascularization? I think if we were to go to the OR, one of the things we've done is actually to try to do mechanical circulatory support coming off pump. So do the bypass, and then after that, you put them on MCS to cool off and recover their function.
Now you say, Marco, obviously we'd have to think about revascularization for him, but I'm guessing that would be based on stitch then? Yeah. Where you're really seeing the benefit out at 10 years, not at 1 year or 2 years or something, right? Okay. So good thoughts. So we actually had a heart team review for this patient, and the surgeons felt he was, at least at this time, exclusively too high risk. And the conclusion with involvement of our specialists in heart failure were to advance guideline-directed medical therapy for ischemic cardiomyopathy. So the patient continued to be stable over the next 3 months, and he saw one of our heart failure physicians who then revisited the issues of surgery for him with the same conclusions. And his dyspnea at this point has moderately improved. But he's continuing to have truly exertional angina symptoms, and his physicians, his primary cardiologist and the heart failure physicians, so he's seeing a lot of cardiovascular specialists, are advancing anti-ischemic therapies, and he has persistent lifestyle limiting symptoms. His echocardiogram at least seems to have improved with guideline-directed medical therapy to 25 from 15%, still quite low. And so now the issue becomes also, again, does he need revascularization, and if so, how? What about a defibrillator for this guy? And if you do revascularization, he's gonna have to wait another 90 days at least to receive a defibrillator. So what's the timing of all this? Alan, your thoughts?
Given that he's have global viability, I would bite the bullet and go for surgery, and I'll call Joe Wu and tell him do it fast. Don't, do it fast meaning that not on pump for a long time, all that stuff, quickly revascularize him. And if you can use all arterial grafts, great, but get the LAD done and then do whatever you can, but really sort of minimize the ischemic time. And if you can come off pump, great. If not, then you support him at that time. And I think he needs revascularization. You have waited 3 months, which is fine, to get medical therapy on board to help a bit, but he's not going to get better without that.
So I just want to Two quick points. One, I think I'm all for all arterial grafts. I don't think this is in this case, it's a Lima LAD vein. What we've done with some success actually is we put in an Impella 5.5 and we plan to come off on Impella 5.5 and just let them hang out for a couple of days before we wean them off. And I think there's some benefit to that in these low EF cabbages with viability where you just don't want to crank the heart immediately after you've imposed a surgical implant.
I agree, but it's a similar thing as, protected PCI, left main angioplasty, everybody need an impeller. No, you do it fast and you're done in 5 minutes and you sort of get rid of all the vascular complications. So there's a balance. He's a young guy. Yeah. So I think there's a chance that you can come off pretty quick without buying all the other complications. But obviously I'm not a surgeon, so I'm going to try to find the best surgeon and basically do the surgery as fast as you can. Arterial grafts as best as you can, obviously vein grafts.
I mean, we do a lot of the 5.5 and kind of let everybody cool off and then gradually wean. And I think that's important because let's be honest, how many of us, this is almost to me like a 57-year-old who showed improvement on medical therapy after 3 months and is still here with viability. Like, we never get that. Like, this is like, right? Like we always get.
They all have no viability, right?
Like of all the cases to make, I would be like on my surgeon. I don't care if you use a 5, whatever, because this person is symptomatic, has an EF, and honestly, would I want to put a defibrillator in someone when I think they still have some reversibility? I would say just go for the surgery.
Alan, would you ever think about high-risk PCI for him?
I think let's say that the LAD is not CTO, meaning that sometimes you see a 90%, 99%. You could do one of the most important vessel first and then buy him some time. But in a 57 years again, I would say, should be able to go through surgery, even an EF of 25%.
So your motivation for it would be especially because completeness of revascularization may not be possible for this case.
Right, and how long are you going to be, if you're CTO doing two things, it might take a while for you to get better.
Sorry.
Yeah.
I have a question for you. How much mitral regurgitation?
But, amazingly, quite little, mild to moderate, but not severe.
Yeah, if you had severe MR, be really careful about the surgery.
Yeah. Good thought, Pam. Yeah, a great point. So he wants to get better, right? And he wants the best opportunity. Actually, what motivated a lot of the discussions for him to revisit revascularization when he was initially told, and I wasn't part of those conversations, but when he was initially told it was not an option, it was really because he didn't want to get a defibrillator. And he was hopeful that with medical therapy that there was maybe some perception things were going to get so much better that he wasn't going to need a defibrillator. And that for him mentally was a hinge point for him in his decision making. So simultaneously, the patients revisited again for revascularization, but at least in these conditions, in our institution, he was still not considered to be an ideal candidate for bypass surgery. And all of your thoughts for high-risk surgery and hemodynamic support, which is commonplace to us, were considered. And then there was this issue about revascularization percutaneously for him. And I think that just in general, when we're talking about these types of patients who are the so-called surgical turndown or just the simply high-risk complex patients that are transferred to these higher centers of care, there's this belief that, hey, if you've got such bad blockages that if you don't get this done, you're going to die, and or your heart function's going to improve or something like that. And all of the evidence doesn't necessarily support that type of decision making. And so it's very hard for us as practitioners, whether we're surgeons, interventionalists, non-invasive cardiologists, or others, to deny patients revascularization therapy, even though it might not necessarily be in their best interest. At least for interventionalists too, we need to have a close look in the mirror at who we really are, right? And we need to reassess what are our skill sets for achieving high-risk complex PCI success. What are our tolerances for risk? And equally, what we're telling patients, is that really in their best interest, and are we truly informed of the evidence basis as well? So interestingly, at least for PCI, even with the presence of viability, even with the presence of completeness of revascularization, high-risk percutaneous revascularization in patients with LV dysfunction, we know from BESIS-2 does not significantly improve their avoidance of death or their likelihood to avoid heart failure rehospitalization. And most importantly, too, while numerically there seems to be a benefit for completeness of revascularization, it doesn't achieve statistical significance even over long-term follow-up. And so having viability everywhere, at least for percutaneous revascularization, isn't necessarily going to guarantee an improvement in ejection fraction as well. Disappointingly, and contrary to much anecdote by many of us as practitioners, when we perform percutaneous revascularization for these patients, even with completeness of revascularization, we can't guarantee an improvement in left ventricular function for these patients with moderate to severe LV dysfunction. Now that said, for those individuals who do achieve, however, whether it's through medical therapy, whether it's through revascularization or the combination thereof, for those individuals who do achieve an improvement in their ejection fraction, however, they do realize a benefit with regard to improved survival and avoidance of rehospitalization for heart failure symptoms. And as Alan introduced briefly too, we do know, however, that at least with percutaneous revascularization and likely with surgery, we're going to improve patient-reported symptoms of angina, at least in this instance by the Seattle Angina Questionnaire over short-term and long-term follow-up from the ischemia trial. Indeed, in that trial, not specific to this individual, but in the context of angina symptoms, the number needed to treat is only 3. And as Alan and Pam have discussed too, at least in ORBITA 2, there is an objective improvement even after a drug washout or in drug-naive, anti-anginal drug-naive individuals with PCI improving angina symptoms. But indeed, it was actually 59% of patients who had residual symptoms of myocardial ischemia. And that may be, as Pam introduced, not so much a failure of therapy, but a failure of diagnosis as well. Objectively, however, we can share with this patient, though, that we should, with revascularization, improve his exercise time, his quality of life with regard to symptoms and improvement in his functional capacity as well. So in summary, when we're sitting down with this patient, can I improve survival with high-risk PCI? No, at least not predictably. Can I predictably improve left ventricular function or avoid rehospitalization? At least the evidence basis would suggest that's not the case, but we can reduce angina. And all of this has to be taken in context of what are the risks of a complex high-risk PCI procedure. And we studied this issue at 25 leading centers in the United States in the Optimum trial of nearly 750 patients who were deemed not suitable candidates for bypass surgery by the heart team. So each center had a surgical principal investigator and an interventional principal investigator. And with high-risk PCI in these patients, the complication rate approached 10%. And in-hospital mortality approached 3%, and it nearly doubled by 30 days. So we compared these patients to their estimated STS risk score and found that actually PCI does similar, but not necessarily better than at least what might be predicted by surgical models. So when we think about this patient, we really are following the pathway of ORBITA 1, in which, unlike ORBITA 2, where we take away anti-anginal medicines or we take drug-naive patients and in clinical practice, we escalate anti-anginals and then think about PCI when anti-anginals are incomplete in their efficacy. And this is really the pathway of the ORBITA 1 trial in comparison to ORBITA 2 that was discussed. So actually, I insisted that this patient receive a defibrillator first. And Sandeep Goyal is in our audience with us today because I just didn't think that we could, based on the evidence, predictably improve this patient's ejection fraction to the point where he may not need a defibrillator therapy. I didn't want him to wait an additional 90 days afterward, and Sandeep was willing to do that. And this was really a multidisciplinary discussion with our heart failure team, with our electrophysiologists. These are not 15-minute new patient clinic visits, by the way. This was like an hour-long discussion in clinic with this patient of going through the evidence in a practical fashion. But but per the patient's preferences, we brought him back to the cath lab. We achieved integrated guide wire escalation recanalization of the CTO. And I did this with a lot of intravascular imaging, so we used a little contrast for it. And I actually went over in the same setting, and he actually had very severe disease too, Alan, by intravascular ultrasound. And so I ended up doing the CTO and the left main as well. And so what can we expect for this patient? So this patient is perhaps not so much like ORBITA, but like this optimum patient population where there are meaningful improvements in self-reported angina, self-reported heart failure symptoms. And in this study, for instance, among nearly 60% of the patients who had angina at baseline, it was reduced to less than 20% at 6-month follow-up. But what's interesting about this from a high-risk PCI strategy is that completeness of revascularization did not necessarily improve clinical outcome, as evidenced also in the BESIS trial, but it also didn't necessarily predict the likelihood for improvements in self-reported symptoms. So we could do a complete revascularization and symptoms would improve, maybe targeted PCI of treating the most severe disease or greatest disease burden and not treating the chronic total occlusion elsewhere, for instance. And as Pam suggested, maybe we don't do anything and patient symptoms may improve as well. So in summary, I'd share with you that in patients with angina, PCI doesn't reliably improve LV function or necessarily mortality. It does improve angina and quality of life, but still many patients may have residual symptoms. And again, it probably reflects more our limited abilities to attribute symptoms to epicardial coronary disease. But most of our patients remain underrepresented in major clinical trials. And more often than not, as in this case, there's not a singular trial, but multiple studies that would inform the shared decision-making process. And that process is really conditioned by a physician's self-appraisal of his or her skill sets, whether you're a surgeon or an interventionalist, your knowledge of the database and your ability to extend that or share that with patients and their families, and ultimately the patient's preferences and symptom burden as well.
Thank you.
Thanks, guys.